Thanks a lot. So, Dave, thanks for having me. I'm going to talk about some of the work that we've been doing on trying to work a little bit on the neuroscience of what the anesthetic drugs are doing. And I'm going to do this by going over sort of three things. The first part is going to be a little bit about loss and recovery of consciousness of propofol, sort of the neurophysiologic signatures of that. Then I'm going to talk a little bit about burst suppression for a number of reasons. One, just to illustrate the importance of trying to work hard to understand the mechanisms of a particular process. And burst suppression is actually clinically relevant. Pretty much all of our patients, particularly patients over 60, as soon as you give them a bolus dose of propofol on induction, they go right into burst suppression. So it's going to compel us to understand it. But I also want to show you that because we've done some work on trying to control burst suppression. So I want to illustrate that. And then also I want to speak a little bit about this idea of reanimation, sort of maybe bringing folks back from anesthesia. This is work which is being done by Ken Salt. And so we've just been talking about reversing neuromuscular blockade. Maybe what we should do is also bring people back from the states of unconsciousness and of anesthesia. All right, so to make my first point, I'm going to show you what we, at least those of us here who are clinicians, I'm going to show you something that we see every day. But I just want to, it's probably a bit of hyperbole for emphasis.
Go off to sleep.
But I'm just going to do it. So a gentleman here who is 68 years old, who's coming to have a hernia repair, there's nothing, nothing special about his case in particular aside from that. It's just that one Friday afternoon, Eric Pearson, I just wanted to go over and just film what we do, because I wanted to just illustrate, something about the changes in the clinical symptoms that we see, but perhaps we don't pay attention to. So what I'm having to do here for the moment is just track my finger doing smooth pursuit. Because okay. I'm going to have him do that.
Now, let me just check one other thing here. What I'm going to ask you to do is, so I'm just going to turn your head. Just let me turn it, okay? You don't have to, but I'm going to turn. Yeah, there we go. Good. I'm going to turn your head.
All right, so that's just the doll's eye maneuver. I mean, you know this. You turn your head this way, your eyes go the other way, right? And the reason neurologists do it is to look at the midbrain. All right, the midbrain and the pons. All right.
Very good. We'll do it two more times, one more time. Okay. I'm going to pull down, you pull up.
Do you mind giving a little midazolam?
And this here, I just want to show you, he's got normal motor strength at baseline. He's not weak at baseline or anything like that. Okay.
Open your mouth a little bit if it helps. Okay, this is the most important thing we're going to be doing.
So we're fairly conventional in that.
Deep breath in.
We pre-oxygenate also.
And then forcefully blow it out.
Have him pre-oxygenate.
Another deep breath, as deep as you can, and blow out.
And then right here,
I want you to just watch it. Just
right here where the words come on the screen.
You may feel warmth in your arm.
Right here where the words come on the screen, we just give him a bolus of propofol, all right?
And what I'm going to ask you to do is, if you can no longer do it, I want you to tell me. You tell me if you can no longer do it. This is fantastic. Just keep doing it. Just keep doing it. That's great.
So now watch. His eyes fixed in the midline.
If you can no longer do it, just tell him. Sir? Sir, can you hear me?
All right. Last flick.
Just going to give you a deep breath here, okay?
All right. All right. So now his eyes are, so 3 points. So his eyes are fixed in the midline. He's unresponsive. All right. Fixed in the midline, unresponsive. He's not breathing. And just the last point here. Watch this. All right. His arm's spaghetti. All right. That's just the bolus of propofol. There's no muscle relaxant there, like whatsoever. All right. So what just happened? All right. So the reason I just want to go through this is just to remind you of something which is obvious kind of after the fact, and that is that we can start to say a lot about how the anesthetics are working just by thinking clinically and just using our clinical exam. So the first thing is here. I put this up here because this is how the blood supply gets to the brainstem. So the two vertebrals fuse and form the basilar, and the basilar runs on the underside of the brain right here. So it's running like right along here. All right, now, right along here here are the respiratory centers. And if you've ever looked at the neural circuits of the respiratory centers, you have this collection of inhibitory and excitatory neurons that work like this. I mean, they basically control the respiratory rhythm. So it's not surprising that if you give a drug like propofol, which enhances GABA inhibition, that you're going to take out the respiratory center. So it's not surprising that you stop breathing as one of the first clinical signs that you see. Now, the basilar artery courses up through here. So remember, this is before it gets to the top of the circle, it gets to make its contribution to the circle of Willis. So it comes along right here, and if you look here, this is where the major major arousal centers sit, all right? And it has taken me a while to kind of get my head organized about these things, but there's actually a nice sort of symmetry here between the sympathetic and parasympathetic nervous systems, all right? And it's something like this. So if you look at the guys in the front and the back, if you look at the green guys here, at the basal forebrain, and then the lateral dorsal tegmental area and the pedunculopontine tegmental area, these are cholinergic centers, okay, in the front and in the back. So basal forebrain, and here in the midbrain, lateral dorsal tegmental nucleus and pedunculopontine tegmental nucleus. In the middle, these guys here that sit in the middle are the monoaminergic centers. So locus ceruleus, dorsal raphe, tuberomammary nucleus, which releases histamine. And there are other dopaminergic centers. I just put the ventral paraqueductal gray here. I'm going to talk about the ventral tegmental area a little later on. Then there's a half. There's like orexin, which is from the lateral hypothalamus. So it's like 2.5 centers, not just 2.5 sort of types of arousal transmitters, if you would, or a class of arousal transmitters. Now, why am I mentioning this? Because remember, for consciousness, you need two things. You have to have sort of arousal and cognition. The two have to be together. So you can take away consciousness just by killing either one of them, right? So when you get a bolus dose of propofol, right, as this gentleman just did, we saw that his eyes fixed in the midline. Now, going back to the clinical exam, why do the neurologists care about, that particular aspect of the oculocephalic reflex? Because it's cranial nerves 3, 4, and 6, right? So 3 and 4, the nuclei sit right here in the midbrain. 6 just sits right on the other side, just sort of the top of the pons, all right? So it's an inference, right? The inference is if I take out the nerves that control the eyes, it's very likely that I've affected those arousal centers as well. I've taken them out, and as a consequence, we see the unconsciousness. And it's actually better than that. You can make an even stronger inference, because if you look at the projections onto these centers here from the preoptic area of the hypothalamus, the projections onto them, it's like my fingers here. Here's the preoptic area of the hypothalamus sitting here. Here are these arousal centers. They're all GABAergic, all right? So as soon as you give the propofol, right, basically it takes out those centers. So you can actually see the clinical, what a component, not the whole thing, a component of the clinical scenario we just saw there, all right? The final piece is this flaccid paralysis, all right? And I put this little guy over here because NASA's interested in this stuff, because the astronauts, when they come back from the long-duration space missions, you never see a news conference with them right away, because they can't. I mean, they've been in 0 Gs for an extended period of time. The shuttle lands. It was another successful landing of the Space Shuttle Discovery, right? And you don't see the astronauts, right? Then you see them a couple days later. It's because they've been in 0 Gs and they're basically like spaghetti, all right? Now, there are a number of reasons for this, all right? But one of them is sort of derangement of the motor control system. And 2 of the main relay centers sit right here in the pons in the midbrain. I've put them here, these 2 relay nuclei, the pontine reticular nucleus here and the medullary reticular nucleus, all right? And they actually sit very close to the surface here. So let me just tell you a clinical correlate before I tell you what's happening here. Again, from our neurology colleagues, if you have a patient who comes in with a pontine stroke, all right, they get a clot in the basilar artery, all right? The way they present is not with a spastic paralysis, right? They actually present with a flaccid paralysis, all right? So this is known. So if you take out these nuclei here, if you take them out, right, you can get a flaccid paralysis, kind of like what we saw. Now, that's not the only thing that's happening here with that patient. There's also direct effects on, primary motor cortex, direct effect sort of at the level of spinal cord. But I just wanted to do just a little bit of clinical arguments to show how we can think about how the drugs are working. And so there's a major effect in the brainstem right off the bat. All right, now, so I'm going to tell you about this work, which has been done primarily by Patrick Purdon, there at MGH. And so to begin with, I'm going to talk about the EEG. So the top one here is what the awake EEG looks like. And if you look at the awake EEG, it's about 5 microvolts. All right, it's not very, it doesn't have a very, very strong amplitude. And it looks, it's called irregular, desynchronized. It's not clear that those are appropriate terms, but that's how it's often referred to, particularly by the people in the sleep literature. Now, what you'll see is if you watch the monitor, watch the EEG on the monitor, when you give your bolus dose of propofol, like I did with that gentleman, one of the first things you see is the appearance of these very, very profound slow oscillations right here in E, all right? Little less than 1 hertz, somewhere between about 1/2 to maybe 3/4 of a hertz. They're very, very obvious. They're not subtle at all right? Then the place, again, and this is propofol, the place if we're running like a propofol infusion where people tend to stay when we're maintaining these states of unconsciousness is here with a mixture of 2 rhythms. There's a slow oscillation, which was there which was induced, and then the slow and sort of alpha oscillation, which is about 10 cycles per second. So you've got 2 big pieces. You've got a slow oscillation like this, right? And you've got this sort of 10 hertz oscillation like that. All right, so that's what I'm going to be talking about mostly. I mean, we all know that, and we see this too, that you can go deeper, and this is burst suppression. And I can tell you, if you watch the monitors, when you induce patients, pretty much all the elderly patients go right into burst suppression with our standard doses, all right? You can go to isoelectric states, and those bursts, the time between those bursts can be quite long in some of these elderly patients, all right? And then the sedative states, which look something like this, and this is what we see very often if we're doing like a propofol infusion, or actually even better, after you extubate the patient. If you leave the EEG on and just watch it, and you say, well, why is the patient sleepy after I've extubated them? They're basically sitting in a sedative state like that. It's a very regular EEG. It's very easy to see, all right? And then paradoxical excitation. I'm not going to spend much time talking about that. All right, now let me translate this to something which we can watch in the OR. So this isn't that gentleman's EEG, but it could very well have been. So this is what I was just saying. So this is a spectrogram, so it's a breakdown by frequency with respect to time. Spectrogram or DSA or compressed spectral array, however you want to call it, all right? But basically it shows the frequency decomposition over time of this EEG signal as someone's under anesthesia. So the induction in this case was given here, the induction dose of propofol is given here. The person's into the slow oscillations and then develops into a 10 hertz oscillation. You can see 10 cycles per second. The redder, the more intense. You can see here's the high intensity. This is the lower intensity. And then this is in decibels. So these are log orders, changes in power, basically. And what you're looking at is the amplitude of the rhythm here as a function of time, is one way to think about it, right? So the punchline for the moment is, when you're well anesthetized with propofol, you see this 10 hertz oscillation, you see this slow oscillation. All right. Now, another very, very quick point here. These oscillations are not small, they're quite big. Again, if you're sitting there with a resting EEG, it's only 5 microvolts. But these things are 20, 50, and in kids, it's amazing how large they are. So they're huge. If that's the case, right, if they're this big, if you think about what happens, you have to be engaging large numbers of circuits in the brain and getting them to do precisely the same thing, all right? So within that, there has to be some insights into how the drugs are working in the brain, all right? That's sort of the conjecture. So if you ask, what have we tried to work on in our research, is to try to understand this and try to understand the extent to which these dynamics help us understand how the drugs are working. All right. So before I give at least the conjecture as to how that's happening, I want to show you another phenomenon, all right? This is well known, all right? So if you stand here now and you close your eyes like this, and I put electrodes in the back of your head here, I'll see a very regular oscillation at 10 hertz, the alpha oscillation. It'll be like this. It's very robust. It's very easy to do, all right? And maybe 10% of people don't have it. You know, we tend to lose it as we get older. But it's occipital. It's in the back of the head, all right? Now, almost, more than 30 years ago, Mitchenfelder and Tinker pointed out that with anesthesia, we have this phenomenon of anteriorization, that the power moves from the back of the head to the front. It does this, all right? And I can tell you, it also does the reverse when you come to. It does this. It goes backwards. Then you'll see someone come to, all right? Now, so I'm going to show you that here in a little video. So this is data taken from one of our studies where we gave patients systematically increasing doses of propofol targeting different effect site concentrations, going from 0 up to about 5 micrograms per deciliter. And so what we're doing is they have high-density EEG. So at each location on the scalp, there's 64 in all. I'm just showing you 44 here. You measure the EEG. You compute the spectrogram. So if you look back here, this is the back of the head. This is the occipital area. Here's the nose. Here's the left ear. Here's the right ear. All right? Now, this person we always have our study subjects start with their eyes closed, so he's got the eyes closed. And if you look right here, you see this band right there. That's at 10 hertz, that's at 10 hertz. See, it goes 0, 10, 20, 30. All right, this says baseline. The person's gotten no drug, all right, no drug whatsoever. All right, now, so I'll just start this. All right, so no drugs administered yet. Now the first bit of drug is being administered. So this is an infusion to sort of target this first effect site level. So now it's at 2. You can see it's fading out back here. All right, now I'm going to stop it right here. Now we haven't even gotten to the highest dose yet, okay? But you can already see that the 10 hertz oscillation has disappeared in the front. And if you start about here, this is roughly the center of the head, and here's the front going forward. So there's a different dynamic starting from this point here going this way compared to the dynamic that you see from here, let's say, going this way out to the sides, okay? Remember, here's the parietal region, this is occipital, and this is frontal, this is over the frontal cortex there, all right? I'm just gonna play a little bit further. Now this 10 hertz oscillation, there's the 10 hertz oscillation in the front, and it's really intense now, all right? Very intense. And now here's the highest level, right there. Now, if you back on the drug, right, watch what happens. It disappears, right, and it reappears in the back. Here it is, okay? And this is when the person comes to. So this dynamic, right, of going forward like this and then coming back is a very robust marker of change in state under anesthesia. There should be something there that gives us some idea of like what's going on, all right? So I'll just give you a quick summary of some of the things that we've sorted out and give you some idea of like what are some of the open questions. All right, so this is propofol, all right? So what propofol does is it comes in and acts at these GABAergic sites, both here in the cortex, so inhibitory interneurons, and here's that network I was talking about before. You see, sitting right here, projecting out from the hypothalamus, is all these inhibitory centers. So it's a perfect setup for any of the GABAergic drugs, right, to have this effect. It's a perfect setup. You just take out these centers, and you have a profound effect, essentially, on the entire brain. And what I don't have on here, because I didn't know it existed at the time, is the thalamus. All right, so the thalamus is missing. But there's a very strong inhibitory effect, right there also. All right. Now, so that's theory. Here's what you see in the operating room. So this is just, again, like another patient, induction. Right here, there's the alpha oscillation, there's the slow oscillation. So what's happening? All right, so we've looked at this two ways. So this is kind of what I showed you from our high-density EEG studies. You see this right here, this concentration of power. All right, now, so here's the first factoid. What we learned from our high-density EEG studies was that when you saw that 10 hertz oscillation forming across the front of the head, it wasn't just there kind of willy-nilly, all right? It's highly coherent, all right? So the oscillations across the front of the head are moving, and 10 hertz are moving very much in unison, all right? Now, with the help of Nancy Coppell, who's a mathematician and an expert in dynamical systems at Boston University, we worked out what were the possible sources of that oscillation, doing some modeling, all right? And what Nancy helped us sort out was that the most likely candidate